Good morning, everyone. I really need the mic today, and I apologize for my very croaky voice, which I lost 2 days ago, and thank goodness some came back today. So today, I would like to thank the organizers for this unique opportunity to talk about Mimosa, which is our mobile technology for screening and follow-up of oral potentially malignant disorder patients. And next slide, please. And I'm going to focus on basically why we work on oral cancer and oral potentially malignant disorders, and what is the role of telemedicine in this disease. And I will walk you through our journey in developing Mimosa. And at the moment, we have already implemented Mimosa in collaboration with the Ministry of Health, and I'm going to tell you some about that. And of course, this session is all about AI, and I'm going to tell you about what we're doing in that space. So oral cancer is really an Asian disease. Why do I say that? Because 3 out of 4 oral cancer deaths in the world are going to happen in Asia. And if you look at the ASEAN top cancers, oral cancer is number 5. The good news is that there could be a window of opportunity for early detection, because many of these oral cancer cases are preceded by potentially malignant disorders, or OPMD in short. So again, you can see that the prevalence of OPMD is the highest in Asia, naturally. And basically, these oral potentially malignant disorders, as their name suggests, they have a propensity to transform into oral cancer. But not all of them will have that propensity. So the idea really is to detect these early and really follow up the patients. So the challenges in low and middle income countries is we have a very high burden of oral cancer and OPMD, and we have very limited number of specialists, and many of these patients who have oral cancer and OPMD are really the ones in the category of B40, or they live in very geographical barriers. They have geographical barriers in accessing healthcare. And basically, if you look at the lesions, as I show in the previous slide, white patches, the one at the top is speckled, the one at the bottom is plaque looking. You don't really know which ones actually are has the high propensity of going into oral cancer unless you are a specialist. So therefore, it's very important that these patients are classified correctly, and they need to be at the clinic. They require a clinical oral examination by a specialist. And once they are diagnosed, they require lifelong follow-up. So therefore, in order to address some of these barriers, we really require innovative solutions. But early detection not only saves lives, it also saves money. Our cost effectiveness study with University Science Malaysia has shown that if you treat OPMD versus oral cancer, it will take you more than 10 times the cost to treat the cancer than to treat the oral potentially malignant disorders. So what are the opportunities for early detection? So oral cancer, I mean, all of you check your mouth, you brush your teeth, right? So it is one of the very few cancers that can be photographed. And everybody has a smartphone in this room. Who doesn't have a smartphone in this room? Please put up your hand. I don't think anybody who doesn't have a smartphone, or you don't have a smartphone, Dr. Cheong. So even the people in the villages, actually, they do have smartphones. And if you look at this particular pie chart, you can see that we are in a region where there are the most number of smartphone users. So we're in Asia Pacific. Majority of the world's smartphone users are actually in Asia Pacific. This is a very unique opportunity. And if you notice, when you have smartphones, you already are doing teleconsultation. Whether you like it or not, the world is moving forward. This is a WhatsApp message that was sent to me by our collaborators in Sri Lanka. And Sri Lanka is one of the least developing countries. And people in the villages are sending the doctors these kind of pictures, asking whether they should be referred or not. So therefore, whether we like it or not, we have to move with times. Therefore, we built MIMOSA, which is short for Mobile Mouth Screening Anywhere. And the vision for MIMOSA is really powering access to early detection of oral cancer for everyone, anywhere. So what is MIMOSA? Basically, the functions of MIMOSA, it enables image capture in the lesions of the mouth. It sends images, facilitates communication between healthcare volunteers in villages with clinicians remotely for a preliminary diagnosis. And it facilitates referral decisions. So by looking at an image, the clinician will be able to say what is the next course of action. So this has been going on for some time, so I don't have time in 20 minutes to go through everything. This is basically the history. So we just started with a very basic project in 2017. We lined up patients with oral lesions, we took pictures, and then we asked the doctor to diagnose the patient. And 2 weeks later, we asked the doctor to read the images. And basically, in that study, we just want to see what sort of mobile phone specifications do you need, and whether you actually get high accuracy or not. And in that study, we saw a 85% accuracy with regards to reading images through the mobile phone. So that gave us a lot of confidence in moving forward. We built the first generation of MIMOSA, and basically this was for remote areas. We tested this in several villages, and you can see that we also did feasibility study, meaning we asked the dentists, the patients, what to think about that, the specialists, and the clinical testing was F1 score accuracy was 93.3%. And this was actually in quite a high number of patients. So as we were finishing this study, COVID-19 pandemic hit us, and instead of being any more a research project, we were asked by our clinicians to make this available to patients, because as I mentioned, patients who have OPMD, you need to follow them up lifelong. So every 3 months, every 6 months, depending on how aggressive the OPMD is. And during COVID, number one, the doctors could not open their clinics because they were frontliners. Number two, patients were very scared to come to the clinic. So what we did was we built the second generation of MIMOSA, no longer talking between the dentist and the specialist, but talking between the patient and the specialist. And these are pre-diagnosed patients on follow-up. And what we did was we did a video how to take the images for the patients. We gave them a link, they download it on their mobile phone, and we made this as a study. And the nice thing was that after the study, we actually did a SUTEC analysis, and we found that the acceptability was very high. More than 90% of the patients say, please make it available as an option for our care. And subsequently, this was approved as a teleconsultation tool in UMMC. But that deviated a little bit from our B40 group. So after the pandemic, we went back, nicely supported by the Ministry of Science, Technology and Innovation. We started to build the third generation of MIMOSA, a scale-up industrial grade, and then we did our implementation study. So just to highlight to the Malaysians in the room, in case you don't know, there are 4 cancers that are within the Ministry of Health are opportunistically screenable cancers, and oral cancer is one of them. And there are guidelines with regards to the Ministry of Health, where do they do the screening. And I said opportunistic, so what they do is they go into communities when they conduct activities, and every time a patient's on the dental chair, they do the screening. And they will make the necessary referrals. And the National Oral Health Plan 2021 to 2030 is very clear. You need to increase stage 1 detection, currently 15% to 30%. This goal has been there for quite some years. We are moving very slowly, but we're moving. And the 12th Malaysian Plan is to increase equitable access to healthcare. So while we're doing this kind of projects and creating MIMOSA, we work very closely with the Ministry of Health. We make sure that we try and close the care gap and meet the national goals. So is oral cancer screening new and unique to Malaysia? No. So there are many studies in different countries, and these are the 4 major ones in India, Taiwan, Japan, and Cuba. I'm not going to go too much into this, except that what are the lessons learned in these screening programs. The lessons learned are that how is screening successful or effective? Number 1, when you screen, there must be high accuracy, meaning if you say it's an OPMD or a cancer, then it basically has to be quite high in terms of accuracy, or else it won't be cost effective. The benefit is seen if there's compliance. So after screening positive, patient has to go to the clinic. And of course, as Dr. Anand has alluded to, screening is not a one-time cross-cutting activity. You have to continue screening because patients who may be negative today may be positive in the next few months. So how does Mimosa help in addressing this so that we can improve upon our screening strategy? So if you need high accuracy, currently the teleconsultation, the image is sent to a dentist who is trained. So in that way, the chances of calling an OPMD will be higher. Second, Mimosa could also enable tracking of patients. So if your patient did not turn up in the clinic, we will know. Number 3, Mimosa helps with systematic data collection so that the next time you go into the village to screen, you know exactly who has been screened at what interval and who hasn't been screened and who are the high-risk individuals that need to be screened. I'm now going to move on to the implementation study, but I would like to just acknowledge that this project actually is a super multidisciplinary project. We involve patients, we involve computer scientists, implementation scientists, clinicians, AI developers, and data scientists. And we've chosen to work in Sarawak. Why? Because I mentioned that MOH has an opportunistic screening program, and that's actually doing quite well. So people who come for dental, caries, other issues, they will be screened. But if you look at the distribution of the clinics in Sarawak, it's very sparse, right? And actually the utilization of the MOH clinics is 15% uptake, meaning only 15% of our adult population ever go to the MOH clinic. And even if they wanted to go, there are not that many around in Sarawak compared to Klang Valley or Semenanjung, Malaysia. So therefore, we've taken the approach to make sure that Mimosa reaches the areas that actually do not have these clinics. So therefore, you have to go down to the grassroots, and we have a healthcare volunteer, and these are villages within their own village, where they will be given Mimosa. They will basically screen their neighbors, and Mimosa will be communicating directly with the dentist, review all the images. If there's an image that is suspicious, it goes to the specialist. Specialist will advise the dentist what to do. Dentist will tell healthcare volunteer. Healthcare volunteer will give a card to the patient if they need to go directly to the specialist or directly to the dentist. So as this is the implementation study, I would like to just walk you through what are the things that we have to do in order to get this going. So actually the Ministry of Health already have healthcare volunteers on the ground. So therefore they have a manual for the healthcare volunteer to recognize what are some suspicious lesions. So what we did with our clinicians here, Dr. Norshalin, who is an oral medicine specialist, and Dr. Roslina, who's public health, we sat together and we created these manuals. These manuals is a modification of what they already have. These 2 manuals are new. It's a module to learn how to use Mimosa for both the dentist and the specialist. In this module, we added how to use Mimosa to the existing module of the Ministry of Health. We then gone on to train the healthcare volunteers, so we did quite a lot of groundwork, meeting the residents of the 12 divisions in Sarawak. We then asked them to appoint the villagers. We then met with the Ketua Kampung, and the Ketua Kampung elected the healthcare volunteers, and then the healthcare volunteers were brought to Kuching to do the training. And you can see that these 2 are healthcare volunteers. There's Dr. Charlene teaching them how to take the image properly. And right after the training, we went back to the village with them. They all have uniforms which they are really proud of. And we make sure that when we go back to the village, they can run the show on their own. So Mimosa has been launched recently at the World Cancer Day in February by the representative of the Datuk DG. And this is Dr. Normi, who is the principal head of the Oral Health Division. So where are we now in terms of our current status? So I'm just giving you data for 4.5 months. We've been on the ground since December 2023. Right after signing the MOU with MOH, second day after the MOU, we're on the ground. 58 clinicians trained, 49 are dentists, 9 are specialists. We have 36 healthcare volunteers now. 6 villages are using Mimosa. Actually, it will be probably 9 by now because my team is actually in Sarawak last 2 weeks, opening another 4 villages, I think. And 3 villages already completed screening. So we have already screened 1,000 individuals in 4.5 months. And that's 22 times as fast as what Ministry of Health can do because of limited resources. And that's the reason why we have to work together. The nice thing about it is that 90% of the adult population within the age group of the guidelines of Ministry of Health has been screened. So this is a phenomenal reach rate because usually if you go in and ask people to come out and do screening, you probably get 10% of the village coming. We identified 4.7 patients who required clinical care, and this will be people who require dentist care or specialist care, and 1% suspicious lesions that needs to be followed up. So 14 patients, which was picked up by the dentist to be suspicious, were basically sent to in terms of Mimosa, told by the specialist to say, these patients, you just monitor at the kampong, no need to come. So 14 patients avoided a trip to a specialist. This is a huge thing because usually in this village, you may need to take a 4-wheel drive for 3 hours, ride a boat ride for 3 hours, and get to Miri or Kuching, and then actually the clinic is closed. And then you need to spend 1 night in the hotel. So for a person who come out to the rural area, it's very, very daunting, and likely they're not going to make that trip. And there's a lot of positive feedback from the community. These 3 villages, we trained 17 healthcare volunteers. They are currently coming with us to open different villages because they're really happy that they get contact with the doctor. In fact, they say, we feel like a doctor, we feel included. So that is really important, I think, when we talk about implementation. So basically what we hope the outcome would be, as I say, screening for anyone, anywhere. First, we have to empower the community to care for their oral health, and we have managed to do that. I don't know whether it's going to be sustainable, that's the truth, but at least for now, that's the positive. Number 2, we have increased the reach of oral cancer screening people who may not necessarily be under the Ministry of Health program because of limited resources, and for people who may not have access to the dentist for opportunistic screening. Obviously, the idea is to promote early detection of oral cancer to meet the national goals. We are 4.5 months into the project. I have nothing to report yet for them. So therefore, at the moment, Mimosa relies on the dentists and the specialists to read the images. And the dentists and the specialists are very busy people. Sometimes we tell them you have to read it within 48 hours. Sometimes they take a week, and then we call them and say why. They say we have other programs, we are not in the clinic. So therefore, and this is Malaysia, where the number of dentists and specialists are low, but not that low. There are places like Cambodia where there's actually no oral medicine specialist. So what do? So of course, solution is AI. So we aim to diagnose in a manner similar to an oral specialist. We have assembled a huge database, and I'm going to talk about that in a while. Wide range of diseases, use deep learning, and then basically we need to provide confidence in clinical diagnosis. We need a very strong clinical team. There are 77 countries involved in coming up with this database. This comes from Asia Pacific, areas where oral cancer is high. And we have several publications already in this, which you can read. But the idea is to do detection first. So object detection, the green box is basically annotated by our clinicians. That's why I say it has to have a very strong clinical team doing a lot of hard work behind the scenes. And then the correct output class, AI will tell you where they're looking at the image. So any overlap is great. Oops, sorry. And then we use attention mechanism parameters in order to help tell us where is the AI looking at the image, right? So these are different, basically, algorithms piled onto the deep learning algorithm, whereby this is the input image that, like I show you here, but no attention, you can see that the AI is telling you, I'm looking at this area, right? And then when we put the attention, it will tell you, I'm looking at that area pretty close. But then when we improve the AI further with guided attention, you can see that it's quite accurate. And this gives the clinician a little bit of confidence to know the AI is looking at the right place. So this is what we have made in terms of progress with the AI, and as I say, there are several publications you can read, since I don't have much time to go into that. The first thing I want to say is we are increasing our images. So when we started the project, we only have 2,000 images. And then we had a Medical Research Council grant from the UK, and then we brought in many partners from the US, Sri Lanka, Nepal, Indonesia, and US, and India. And then we improved our number of images, and currently the F1 score initially at 5,000 images was about only 68%. And after we got the grant from MOSTI, we started the implementation study. We continue collecting more images. The F1 accuracy now is 89.2%. It's still not great, but we are not CIBIL, we're not there yet, but this is developed in-house by our collaborators and Cancer Research Malaysia. And we know that probably by 2024 we will hit 30,000 images because we are already implementing on the ground. And we are currently looking at how to improve the accuracy and what it takes to get MDA approval. So in summary, we've developed and tested Mimosa in various settings during the community, during the pandemic, and now back to the villages. We engaged HCV on the ground, increased our screening reach, and the rate of uptake is about 90%. We identify individuals who may have OPMD and those otherwise may not be identified, and enable individuals to avoid going to the specialist and develop a database and algorithm. What's next? Like I said, we're only about 5 months into the project. We target to screen 2,000 individuals. I think we will hit this number by end of 2024. After doing the screening, we send in our clinicians to do sampling to make sure what is the false positive, false negative rates with clinical oral examination, and that's currently ongoing. We will be doing using implementation science frameworks to identify the facilitators and barriers to screening using Mimosa. Why do people come and screen? Those 10% they don't screen, why? And we also have issues about compliance, meaning if they detect, they may refuse to go, and we need to understand why. Lots of data analysis. We are looking to scale up. As I mentioned, my staff is in Sarawak right now. And of course, we have to continue improving the AI algorithms. They're not ready for real time yet. And as I alluded, this is a huge team effort. Mimosa team in CRMY is pretty small, but we work extensively with Ministry of Health, University of Malaya, the civil societies, the app developers. Cost effectiveness study is always ongoing in the background because ultimately we want this implemented, and we know that it will be down to dollar and cents. And of course, lots of statistical support, both from Ministry of Health and from our other collaborators. And I would like to acknowledge our funders. Mainly, the implementation study is funded by MOSTI. We also have support from the Sarawak Digital Economy Corporation, and nicely, the embassy in German embassy in Malaysia supported us. We staged a group of CEOs, so we get our funding quite diversely. We are also supported by grants such as Medical Research Council from the UK and of course our core donors, Yayasan Petronas and Yayasan Saimdabi. I thank you for your attention and for bearing with my very croaky voice. Thank you.